Thank you, Cha, for the introduction of the speakers. We'd like to welcome both our speakers for the webinar today. This is a very important topic. And as you might already know, AeHIN organized the recent general meeting in Jakarta last November, exactly on the topic of putting blueprints to practice. So look forward to hear from you. And then we will have our, after your introduction, after your presentations, we will also have interactive sessions. So I encourage the participants here to please put your questions in the chat and also encourage you to ask. And then you can raise your hands and then we can enable the mic at the end of the presentations. Thank you. Over to Ali and Derek. Welcome. Let's get started. Thank you.
Great. Thank you very much. And for this opportunity to speak to all of you today, I'll just get the presentation up and in parallel talk you through a little bit about how we'll proceed today. So what we're talking about today is a toolkit that the World Bank has supported the development of to create what we call buildable national digital health blueprints. And the word buildable is very important in there, and we'll talk about that. So the way it's going to go is that the first sort of presentation is around an example of where a blueprint was developed with our support and where what the takeaways from that process were. We'll then talk about the toolkit itself, the rationale for developing it, and what people can expect as outputs, what the process that toolkit, using the toolkit looks like. And a big part of the toolkit is an investment case, which is actually based on work that was done originally at an AeHIN conference, which we've then kind of developed, and Derek will walk us through that investment case. And the aim is to get through the slides with about 20 minutes left at the end so that we can have a discussion, take any questions. So that's kind of the plan. And with that, we'll kick right away into the Cambodia digital health blueprint.
Because I was very intimately involved with the country World Bank team, I'll just keep going where Ali left off. Just the key takeaway from this slide, honestly, it's not an eye chart, and I know that there's a lot of boxes there, but the key takeaway is that there were multiple disconnected systems, and that was one of the challenges we wanted to address. The other thing is that I know that I believe it is still going through its processes internally, but an excellent strategy document was developed by the Cambodia Ministry of Health. The takeaway from this slide, the other background information that's important to know, is the ministry had developed an excellent strategy document. It had not yet gone through the internal processes, but we were able, the World Bank team was able to have the document shared to them. It was shared selectively to a few people for comment. And we were able to leverage that and using some of the things that are in the toolkit, we were able to leverage that and say, how should this excellent document inform a buildable blueprint document? So the key thing that we wanted to work towards is a national digital health blueprint that was at a degree of detail that let it be built. So it was not something, if you think of an architect's rendering of a building where they've drawn a nice picture and they drew some trees in front and there's somebody walking their dog. This was intended to go to the degree of detail analogous to the carpenter's drawings and the electrician's drawings and the plumber's drawings, and something that was actionable and could be constructed. The other thing that was important is you would never start any building construction project if you didn't already know what it was going to cost or what you expected it to cost. And so an important aspect of this as well was a cost utility analysis, an investment case. And so the intent here was to say, well, what would we get from being able to leverage digital health at national scale? And then what would it cost us to start where we are now and get to the point where we're able to be leveraging a national digital health infrastructure? Perfect.
Sorry about that. Thank you, Derek, for taking the reins there. So
no problem, my friend. I know you do the same for me. So I'm going to go on mute and turn off my camera, and please, away you go.
Thank you very much. So yes, we basically, to help Cambodia move ahead with their to implement their strategy. Actually, Derek worked with us to develop a digital health blueprint for Cambodia. And this lays out a tactical plan on how to execute the strategy, but also, as he was saying, a 10-year cost-benefit analysis. And this is important because too often we just look at the costs of implementing digital health. We don't look at the benefits. And so this has a model that lets you model when you might see benefits, what those benefits might be, and what might a return to investment look like, and when that would kick in. Okay, so some key takeaways that we learned from that process. One was that, obviously, when you have a strategy, you are missing a tactical plan. But the important word here, and I said this when we started, is the word buildable. And the reason why we emphasize on the word buildable is that very often, even blueprints will be developed, and then they will sit on shelves and never be looked at, never be used. And the nice thing about this toolkit, this sort of blueprint exercise, is that it lets you create something that can be built. It is very much action focused, and the output is conformance testable. It contains an investment case. It recommends a governance model as well. So it's very much giving you all the pieces that you need to have in place that you can then use to actually implement. Thanks. The other one that was important was the sheer advantage that the use of cloud provides, both in terms of interoperability as well as economies of scale. And this also aligned very nicely kind of with the digital health strategy in the country, where an MOH-governed digital health cloud environment was the goal. And so this shared infrastructure should ideally include things like foundational registries. I'm probably preaching to the choir in this group of people, but that was the idea. And so then everything else is also on the cloud. The HIE is on the cloud, and everything else is on a hosted model, so that you're operating in a scalable structure. And this diagram is what was in the strategy, actually. So as you can see, those of you who are familiar with the OpenHIE kind of paradigm will see a lot of similarities in this structure and that structure, where you have a number of shared registries, and then shared services like terminology services, etc. And then beyond the interoperability layer, at the bottom of the diagram, you have the point of service systems that are relying on this overall structure to be able to operate, to be able to exchange information, to be able to scale. Thank you. So the other one was that the advantage of international standards, and why we recommended that this HIE should be based on modern standards like FHIR, and it's a lot less effort to develop something, obviously, when there is a standard in place. The other important thing, and people often wonder, what about all the stuff that we have in place already? We have all these systems in place. You saw the Cambodia diagram, but that's typical of many countries, where when they embark on this journey, before they think about enterprise architecture and the platform approach and interoperability, it's very common for things to have been built in a disconnected way, that are working some at scale in many countries. Like in Cambodia, there's two examples. There's one is PMRS, which is the claims management system, and the other one was FHIR, which was set up in the COVID-19 during the pandemic to handle the vaccination records. And these are systems that are running at scale in the country, but they may not be FHIR compliant. They may not be standards compliant that way. And so what's the question? Do we drop these systems? Do we rebuild them? What do we do? And that's where the advantage of the facade approach, and we'll explore that a little bit more in the second presentation. The whole point is that stuff that is running at scale doesn't have to be set aside. It can be very quickly brought into conformance. And that actually gives the whole process a running start, because you are able to say, look, we got this system up and running. It's been a month. And PMRS, for example, is now FHIR compliant. And that really gives you an impetus. So instead of setting these systems aside, the recommended approach would be to sort of bring them into conformance using a facade approach. And that gives you, as the slide says, a running start. The other one is the importance of computable care guidelines. And an example of these is obviously WHO's SMART guidelines. And why this is important is that you start to see there is literature that shows you that when you use guideline-based care, you are actually improving health outcomes. And so that is where you are able to, when you digitize those guidelines and you incorporate them into your information systems, then you start to be able to gain benefits from the use of guidelines within the system. So you don't have to have those massive books sitting everywhere. The guidelines are actually part of the software. And it tells you what should happen during an encounter. And so this is basically what the guidelines, allow you to do. You're able to find out what should have been done, what was done, and there you can figure out where the problems were, and you can incentivize adherence to guidelines, and you can potentially penalize non-adherence. And then that gives you the ability to sort of figure out what's happening in your health system. Then there's this notion of the economies of scale with shared services and platform approaches, where we were able to see in the and I'll show you some figures soon, but what sort of the cost effectiveness of this looks like over a 10-year horizon. And as we said earlier, the investment case tool that we've used was first workshopped at the 2017 AeHIN conference. So that's been adapted to the tool as part of the toolkit now. So as an example, and this is a model, right? So in the model that we developed for Cambodia, what that model indicated was that an annual budget of $7.5 million, so that's $75 million over 10 years on average, was needed to set up this enterprise architecture and to run it for 10 years. And this includes governance, it includes maintenance of all the systems, and it assumes that everything is being built from scratch. So the actual cost would actually be lower than this. And so this, when you look at it in context, it's less than 0.5% of the country's total health expenditure. And that is assuming that you take a platform approach. We're not talking about siloed investments or siloed systems. You take a platform approach and you take it from there. And finally, very important, governance. And so in this sort of situation where there isn't an MOH steered or an MOH governed situation, then you end up with the Wild West effectively. And so this kind of governance is required, and we recommended an MOH coordinated governance structure, which you can see on the next slide. So this is what was recommended as part of the blueprint. And again, it aligns with the strategy, where the government basically empowers and funds the Ministry of Health to in turn empower and fund a digital health unit. And between the MOH and the digital health department, they coordinate the efforts in the country, which means that they coordinate development partners, they coordinate projects. And so it's the government that is steering this entire sort of enterprise, no pun intended. Right, so this is basically the end goal, where there is the ability to develop, to sort of provide guideline-based care digitally for every Cambodian citizen. And this would mean, everything, all the point of care systems you see on the screen right now would be, linked up to the HIE. Yeah, so now if we could pull up the next one. All right, and we can jump to maybe slide 7, actually, in the interest of time. Okay, so basically, what we saw was that every country was then having to kind of start this process from scratch. And what we would like to do, the goal that we had in mind, was to see if we could generalize this process in a way that could still be context relevant. So not that you have a cookie cutter approach to this where you copy paste the same thing everywhere and it's going to work, but a way for each country to be able to kind of undertake this process, but still have it be relevant to their context. And why we did this was because, for example, countries and governments and multilaterals would be the ones who are best positioned to support scale up of the kind we're talking about. But they would need kind of an investment case to figure out, because there isn't only one thing to fund. There's a lot of things to fund. And so what's the best investment that you could make? Is it setting up digital health in your country? Is it hiring more nurses? Is it solar power? If you have competing priorities, which one is giving you the most bang for your buck? And countries often need help to develop that. And that's the model that the toolkit has in it. But also to be able to sort of figure out a process that can be replicated, where the outcome is always going to be relevant to the country in question. So what works in Cambodia may not work in the Philippines, may not work in Kosovo, may not work in Kenya. But the process is what we're sort of putting into place. Okay, so what are the outputs? There's 3 main outputs. So one is a contextual analysis, which is where the work is done to figure out where the country is. What is the context? The next one is a digital health design specification, which which actually gets quite technical. It gets into the different FHIR interactions, what the pieces are, what the transactions look like. So it really is, in that sense, very much a buildable kind of blueprint. And then the final thing is this investment case that's based on the implementation plan. And this will become much clearer as we go down. So the outputs. So I mentioned the contextual analysis, and that also leads to recommendations around governance and legal frameworks. So what policies currently exist, what might be needed, etc. And so this is what a typical table of contents would look like for a toolkit that is the outcome of a blueprint that's the outcome of this process. So there's a national burden of disease, and this is where we start contextualizing to the country. So what actually are the key health problems in the country? Then alignment with the national health and HIE will look like, what the current landscape in the country is, and what are the quick wins that we mentioned in the Cambodia presentation, what the governance structure might look like, and then an example use case to sort of look at maybe one disease area, say diabetes, and what does this look like if we implement it for that as a sort of a spur to get people thinking. And finally, the investment case. So these are all actionable. This is, that's the important thing. There is a full-blown specification that's part of the blueprint. There's a project plan, which takes you from the current state to the future state. The investment case tells you what that will cost and how it will benefit you. And as relevant to the country, there are also governance and policy recommendations that are part of this blueprint. So what's the process? Basically, the idea is very similar to what has been done in the convergence workshops that AeHIN has been able to execute so well. And so the idea is to have a technical working group, and we recommend that technical working group be multi-sectoral, not just the Ministry of Health. And it's a short project, so this is basically not years of effort. We're looking at doing this in two or 3 months. And that technical working group works with the facilitator to generate the different artifacts of the blueprint. So as I said earlier, this is a multi-sectoral technical working group. We're looking at the Ministry of Health. Other ministries could be ICT, could be Interior, could be Telecom, depending on the country context. Development partners, donors, NGOs, care providers, and obviously other ministries, as I said. Because you don't only want one view. This is something where everybody goes all in and works together. Right, so what does this process look like? There's 4 or 5 different workshops, and we'll talk about each one. But for each workshop, the process is that one, there is material for the technical working group to read. There is preparation that the facilitator does before the workshop happens. There are questionnaires that can be used to get important information from the participants before each workshop. And so in the workshop itself, you're having a discussion, you're not digging up data. And that process ultimately leads to, over a series of workshops, leads to the blueprint document. So this is what the toolkit contains. It contains workshop facilitation aids that includes sample presentations, where you can just kind of drop in what is relevant to the country, a number of different Google Forms to get the information before each workshop. And there's also a template blueprint document. So you're basically filling it up as you go along from workshop to workshop. Right, so what are the 4 workshops? The first one is use cases, where you choose the areas of the health system you're going to address as part of your exercise. That helps you create the digital health specifications, specifically integration profiles that you would develop to sort of address that. The third one is the conformant digital health solution. So what is existing and what can be brought into conformance. And finally, what is the implementation plan? And each of these, as I said, will build on the one before it. So there's 4, then maybe the 4th one might end up being 2 workshops in some cases, because implementation plans can take some time. So we're looking at 4 or 5 workshops. And so, as we said earlier, the use of standards is very important here, because one, it's you're doing something that's been done, but it also helps you mitigate risk. And so what you're using are credible existing ways of doing things versus building something yourself. There's nothing stopping you from building something yourself, but doing it the standard way is probably smarter. Right. So this is where an example of kind of what the level of technical specification that the blueprint gets into. So what you can see here is part of the overall enterprise structure where you have the FHIR server that's got your client registry, a number of other registries as part of it, and then sitting outside it are your terminology services, your facility and your health worker, and your organizational setups, your HMIS. And so this is basically the stuff that's in the rectangle is pretty much drop-in standards-based, can be dropped in one-time effort, and you're good to go. And the stuff that's outside that rectangle are things that would be much more country-specific. And the numbers that you can see on the diagram are actual transactions, and each of those transactions is documented in the blueprint. So you're able to figure out exactly what you need to model and what you need to build to make this work. And this is the facade idea that we talked about earlier. So if, for example, a country has an existing client register or an existing point of service solution that's currently not compliant, you don't have to throw it away and rebuild it. You just create a facade that maps it and makes it FHIR compliant. And that's the advice that we give as part of this process. Some of those things can be made FHIR compliant, maybe some can't, but that's worth exploring with the facade pattern. Some assumptions. So one, we assume an OpenHIE approach, a person-centric data model, a cloud-hosted deployment running on FHIR, and we assume computable care guidelines because that's where the benefit part of this kicks in. Yeah. Right. And so just to summarize, the idea is that a multi-stakeholder technical working group works over a short duration, will develop tactics that align to existing strategies and create an implementable, conformance testable digital health specification, leveraging best practices. And the last part is the investment case. So we are currently in a process of learning as we go. And so this consultation that we're having, this discussion we're having with you today is part of many. We've had several over the last few months, both internally at the World Bank, as well as externally in an effort to improve the toolkit, to sort of talk to people about the approach. Does it make sense? Is it useful for you? Do you see value in it? If you don't, we'd like to know why. And we'd like to update the work as we go. We are also going to be ground truthing this in a couple of countries to sort of make sure the process is correct, and we will share our learnings from that experience as well. That's the last slide. Over to Derek at this point. Thanks very much for the support with the slides.
All right, I'm going to go very quickly because we do want to have time for questions. So I apologize for storming through this very fast, but we're going to talk here about what drives the investment case, where do the data come from that are used in this investment case, and it's a great big linked tab spreadsheet. And then how does the analysis work and how do we reality check things? So the data for the investment case comes from the workshops. As Ali was saying, the toolkit is in fact a way to facilitate a set of workshops. And we expect there's sort of 4 categories of workshops. And in workshop 1, we'll be looking at the burden of disease and the present readiness and simple things like how many health workers do we have? How many facilities do we have? What's our rate of inflation? All sorts of things like that. In workshop 2, we get into some of the technical pieces, and Ali showed a diagram about the sort of the notional architecture and the pieces that make it go. So what kind of architecture and what kinds of digital health solutions are we going to be connecting to that architecture? In workshop 3, we start to look at what's the current state. This is highly contextual. So how ready are we for digital health? How many solutions have already been implemented, and have some of them gone to scale and are good candidates for the facade approach that Ali was describing? And then in workshop 4, we get into the quite sometimes challenging issues of, all right, well, what are the aspects of implementation science that will help us ensure that we can mitigate some of the risks of any large digital project, and so that we can maybe choose pathways of implementation that will address certain issues of our burden of disease first so that we have a quick win. If the whole implementation takes 4 or 5 years, it might be that we can shorten our time to benefit, for example, by doing childhood immunization first and start enjoying benefits in 12 or 18 months while the other projects are underway. So there's aspects of this that choices we make regarding implementation science. So how do we use the spreadsheet tool for this? It's based on activity-based costing. And activity-based costing, notionally at a high level, you just say, well, if there's something I need to do, what is that going to cost? And then across how many sites, facilities, or people do I need to do this thing? So when we're making a choice, for example, about health ID cards, if each health ID card, given our choices, is a simple 5-cent thing that's going to be mostly handwritten, but I need to do it across 15 million people, I take the 5 cents times the 15 million people, and it's going to cost $750,000. And activity-based costing is simple conceptually, but pretty powerful in what it can yield for us. So as I said, this is a spreadsheet, and we have to put demographic and economic information into this spreadsheet. The way the big spreadsheet works is that all of the things that are contextual are in green, so you can pretty readily see what it is that you need to edit. I'm going to go very quickly through these because we're going to share the details later. So I just want to give you a top line message from each slide. Message 1 here, there's a sort of top level demographic information and some choices around penetration rate that we make, and we put that in the spreadsheet. Regarding facilities, we set up 4 cost bucket types. So this isn't just 4 types of facility, but these are large ones that'll cost a lot and take a long time to implement and might be quite expensive to operate. Medium ones, which are a little bit less so. Small scale ones that could be, the heart of our care delivery network is sometimes these clinics that are all over the country. And then there's special cases of remote implementations, or where we've got outposts or single nurses that are working alone, that kind of thing. So we just create some different categories. We associate the facilities with these categories, and then each of them has different types of cost footprints. We also have an expectation that there's things that have to be funded, especially if they're not yet done. Some of these are prerequisites. Even if we do have a digital health strategy, though, we should expect to revisit it. And so there's a kind of a 10-year picture to say if there's something that I need to do, if I have to do it before my launch, those become upfront costs. And even if I do have a strategy and a blueprint and my norms and standards and so on, I should be revisiting these things every 3 or 4 or 5 years. And there's a template here that lets you say how often you'll revisit it. I do want to draw people's attention to the bottom row, which is you will establish digital health governance, and you will exert governance over your digital health infrastructure and your care delivery network for the rest of time. So this, as you see, is an ongoing cost that we should expect to budget for when we're going to go to the length and breadth of the country with our digital health. We make choices regarding how we're going to operate any shared infrastructure, any health information exchange infrastructure. And so one of the options, of course, is infrastructure as a service. We can say, I'm going to have this be a cloud hosted instance, and I'll pay a monthly fee for this instance. Or we can do a private cloud where we're putting our own solutions in an MOH paid for private cloud solution, or we can stick build everything. And of course, anybody who knows me well will know I don't favor option 3, but I know some people may favor option 3, so it's one of the possible ways to approach things. But for the AmalgaLand option, we had door number 1, which was infrastructure as a service. So there's a recurring fee for that. Regarding unique health IDs, you say what kind of identifier you want to issue. I strongly favor just a simple card that each person would have, a wallet ID, we call it. But then these are not forever cards. So how often would this have to be renewed, and how many times or what percentage of people do we expect will accidentally drop it in the river and a new one will have to be issued? So you just put these kinds of assumptions into the sheet, and then you can generate what will be your cost along that axis. Unique health IDs are absolutely foundational, and what will be the expenditures we have to expect to support unique health IDs. A facility registry typically is made up of collecting content from a number of underlying facility directories. And so the cost driver here is how many of these directories do we have? You know, the military might have a list of all the facilities they have. And of course, the MOH will have a list of the facilities they have. But there could be NGOs that are operating in the country. There could be religious organizations operating facilities. However many underlying directories there are, we have to have an interface to each one. We might have to build it, we'll have to maintain it, and those get collected together into the registry. It's analogous for the interlinked registry of health workers. And again, I could have a college of physicians and surgeons, a college of nurses, a college of dentists, a college of pharmacists, where I've got these underlying directories, however many there are. I'll have to have an interface into the interlinked registry for health workers, and then I'll have to expect to manage and sustain that interface over the 10-year period of this investment case. The shared health record has two key pieces. One is that I'll have to be able to connect point of service solutions to the shared health record. So again, however many of those that the ministry is going to have to pay for, there might be private sector ones that will connect under their own steam. But where the ministry is responsible, we have to say, well, how many different point of service solutions are there? And again, what will be the cost for each interface, and what will be the annual maintenance cost I should budget for? So that's one of the cost drivers. But by far, the largest cost driver is not to say this type of application has to connect to the shared infrastructure, but rather, if I haven't already implemented digital health at the point of service, then what will be my costs of doing that? And remember the 4 cost categories that we had: type 1, type 2, type 3, type 4. We say how many are currently already live with digital health solutions, and how many will have to be implemented. And then how quickly will we do that? Will we do 50% per year, basically saying I'll take 2 years to do this, or 25% per year, doing a 4-year period? And then how many MOH interactions per year? Think of this as how many times would you have to revisit or contact each of these point of service implementations to check up on them, to make sure they've refreshed their terminologies, to ensure that their training is up to date. So there's also a governance and management cost that we also want to budget for. Terminology services, this is one that we have to budget for, even if we're making use of free data sets. So if we're using SNOMED IPS, or we're using ICD-11, or we're using LOINC, just because we don't have to pay for the data set, that there's no license fee, doesn't mean that there's no cost. So we should budget for the cost to set up and then manage our terminology services. And underestimating this is a classic mistake in people that are preparing their budgets. They think that the code lists are free, so we don't have to worry about that. It's not the case at all. And I think any of us that have got some scar tissue around setting up terminology servers know that this is something you spend real money on, and you should expect to sustain and support the care and feeding of our terminology service over the whole lifetime of our digital health infrastructure. HMIS, the Health Management Information System, again, we look at how many of these servers are we going to have, and each of these servers should be connected to the shared health record. The reason for that is, over time, we want to do less and less and less reporting of aggregate indicators from the edge of the network, and more and more and more getting these data from the shared health record repository. So we'll want to establish these interfaces. And again, we have to sustain these interfaces over the whole period of the investment case to get a realistic budget figure. All right. What about the benefits? And I apologize for storming through this so quickly, but the benefits come from reducing the no-do gap. WHO refers to the sometimes wide chasm between knowledge and practice as the no-do gap. And there was an analysis done not that long ago, maybe 5 years ago, by the US National Institutes of Health called Crossing the Global Quality Chasm. And this very detailed analysis surfaced that there are about 8 million people on an annual basis that die every year, not from not having access to care, but they die from the care they receive. There are quality challenges that need to be addressed. So the notion of how will we establish what are the benefits of improving care quality and reducing the no-do gap and increasing adherence to care guidelines is we can look to the randomized control trials that supported those guidelines in the first place and say if we can improve malaria care, or we can improve HIV care, or we can improve diabetes care, what would be the impact? What would be the percent of reduction in the disability adjusted life years that we would enjoy from leveraging digital health to reduce the no-do gap? So this reaches back to the workshop number 1, where we did the burden of disease in the country. And we'll pick a top 5 and we'll say, what are the quality adjusted life years that we can gain, or the disability adjusted life years that we can avoid from each of these key elements in the disease burden. And then we can put into our spreadsheet, well, how long is it going to take before we realize the benefit? So if we're in a 4-year implementation cycle, maybe we don't realize any benefit until we get to year 4. And then we can say, what will be the benefit realization? Will we make a 1% difference, or a 2%, or a 20%? And again, we can leverage the randomized control trials that show increasing guideline adherence can have a 30 or 40% improvement in health outcomes. But we put all of these data, we have the cost information, and then we put the benefits information, and we can get an investment case. And we can say, well, when does this start to return an investment to us based on the rules of thumb that WHO's published, that if you can enjoy a quality adjusted life year for less than 1 GDP per capita, that's a great buy. And so we leverage that rule of thumb as our cost effectiveness threshold. And then we can graph this and we can say, okay, well, if I get a 1% impact over the course of this 10-year investment case, my economic ROI is $2 of benefit for every dollar I spend. If I get a 5% impact, it's $10 of economic benefit for every dollar I spent. And so we can see, how does this compare to other ways that the money could have been used? And then we can also do a reality check and say, what are my annual health expenditures per capita now, my total health expenditure? And what's the cost of this digital health investment? And as a percent, one over the other. This is useful because if you look at economies in the OECD, they tend to spend 2 to 5% of their total health expenditure on digital. And usefully, if we're coming into that either in that range or below that range, we've done a useful reality check. And I'm so sorry, I went quickly as I could, and I know we've got just a bit of time left, but please, if there are 1 or 2 questions that we can answer, we will. And I know, Jai, you want some time to close us out as well.
Yeah, thanks, Ali and Direk. Maybe one question, which is very common here. So, AeHIN, as you know, that has been working closely with the countries and helping them with digital health transformation. One question we repeatedly come across is like, I'm sure that this guidance from World Bank will sometime be available for people to refer to in terms of buildable blueprints. But there are countries which do not probably have resources within the country. For example, someone who could, like a roster of experts, or even the financial resources and many things. And it is not it's going to be an expensive proposition from what I could understand. If the countries were to seek help from the World Bank, is there a process? Is it that they approach to the country office, or is there a mechanism by which they can seek support in terms of getting started with this buildable blueprint? That's my question. Thank you.
Great, thanks,
That's
Chaya. That's a great
very much
question.
Ali's to answer.
Yeah, no, I'll take that one. It's a great question because that's what makes this useful at the end of the day, right? So I think, yes, effectively, if you're working in a country and you need support, your go-to should be your country office at the World Bank. Reach out to them, let them know that you're interested in this, and then they will in turn reach out to us. It will not hurt to also drop me a parallel email, for sure. But our funding works typically through our country offices and through existing lending programs or upcoming lending programs. And so it's the country offices that kind of make this happen at the end. We will support that process from headquarters as best as we can, but your go-to should be your country office. And yeah, drop me an email in parallel. That might help. Yeah.
Jai, there's
Thank you,
also a
Ali.
comment. There's a comment that came up at the PMAC conference that I'd like to add to that. And one of the things that all of our country MOHs know is that there are multiple players in the country. Each of the development partners, I mean, UNICEF tends to focus very much on childhood immunization, but where we can start to take investments that are in the country already around childhood immunization and PEPFAR money that's there for HIV, and then PMI money that's there for malaria, but where we can start to gather this together and leverage it as a platform play and do some coordination, definitely that we have to take all of our little puddles and make the appropriate sized inland sea or lake that we need to do our work. And that coordination effort is also something that very much has been my experience with World Bank teammates in the country offices, is that there's that coordination that has to be done as well to say, look, if we're doing a platform, it's not a siloed play, and it's not some idiosyncratic solution that's only good for one element of the disease burden. It's a platform we use to improve everything. And it's a different mindset that speaks to the importance of governance, which I know is, I mean, it's the first letter in our close the gaps. So we know that that's going to be crucial.
Thank you, Derek. I think we lost a bit of a time in the beginning, so maybe we have to cut down now and then close the session. I know a lot of people who are attending right now. Some of them also from our region. Those are countries who are actually in the path of developing their national digital health blueprints. At least I know 3 of them. And then also there are countries who have the blueprint and they are in the path of implementation. I'm sure that I think there will be many. Now that Ali, you have given the license to reach out to you, I think there will be a lot of questions that may be coming back to you. Any take-home message, Ali and Derek? 30 seconds.
My 30-second message is that this is a real, digital health is having a moment. This is the time for us to start to do the implementations at scale. And we've been setting up for that and preparing for it. And now is our time. And it's why, as Ali mentioned, it's why we think this toolkit is important and why it's important now.
Thank you, Derek. Ali, do you have your 30-second message?
Yeah, absolutely. Absolutely. Echoing Derek, I think that this is the time when we need to start talking about scale. We need to start talking about foundations, less of the, my favorite app. Let's put in place foundations that make things work. And we'll support that as best as we can.
Thank you, Ali and Derek, for being with us and sharing about this very important topic. And this has been also very close to AeHIN's efforts in the region. And then I'm sure that this will also be part of our convergence workshops that are happening right now. And then those are in the pipeline in the next months. So we will reach out to you on that as well. And then I would like to thank all those who could spare your evenings, mornings, or afternoons to be with us and enrich this discussion. I also noticed the team from the Digital Health and Innovation Department at WHO headquarters being with us. Thanks very much for you all to join with us. And with that, I think we can close. But before that, I think we can take a nice group photograph on this very important occasion.
Thank you.
Thanks so much, everybody.
Thank you.
Thank you very much for this opportunity. Thank you.
Thank you, Ali. Thank you, Derek.